saying that I don't like really virtual lectures very much. So I did throw in a couple of question slides so that y'all could maybe, we could interact a little bit. But I think this is a really good topic for everyone. And I modified what I usually talk about. I'm talking about the three more common oncologic emergencies: the metabolic complications, hyperleukocytosis, and mediastinal masses. Then I'm also going to talk about some abdominal oncologic emergencies, and hopefully y'all read the article on tumor lysis, and then also read the other article, because I think it has a couple of things in there that are different as far as thinking about and talking about for our patient population. And hopefully y'all read them. So let's get started. We'll start with the metabolic complications. And tumor lysis is the most common oncologic emergency that you're going to potentially deal with. So it's really a good one to have an understanding about. What happens with tumor lysis is that there is a rapid release of the intracellular metabolites from the tumor cells that exceeds the excretory capacity of the kidney. So basically, with everything going on at once, you overwhelm the kidney. Those metabolites include nucleic acids, so the DNA that's in the cells, and those nucleic acids are metabolized to uric acid. Phosphorus and potassium are kind of the three main players that cause problems with tumor lysis. When you have all these metabolic derangements, then what is the result of that is you can have acute kidney injuries. You can have cardiac arrhythmias, especially related to problems with calcium and potassium. You can have seizures, and you can even have death from these metabolic derangements. So first question are, what cancers are we most likely to see tumor lysis? And people can unmute and shout out.
Burkitt's, lymphoma, and leukemia.
Yes, yes. And those are the main ones that we see it in pediatrics. And the reason why we see it in those particular tumors is that we see tumor lysis in tumors that have a high growth fraction. So things that are growing fast. And so Burkitt's lymphoma grows very, very fast. The doubling time is the fastest doubling time of all the cancers that we see. And then we also see tumor lysis in patients who have a high tumor burden. So patients who have lots of disease in their marrow, as well as the mediastinal mass and maybe hepatosplenomegaly or lymphadenopathy, that tumor burden is a risk factor for having tumor lysis. Being very sensitive to chemotherapy is a good thing to be. So having a tumor that responds well to chemotherapy is great, but that also increases your risk of having tumor lysis. So the tumors that we see, Burkitt's lymphoma specifically, T-cell leukemia and lymphomas, and any leukemia that the white count is really, really high. So an AML that has a super high white count or a B-cell leukemia that has a super high white count are at risk for tumor lysis. So what do we do to prevent it, and what do we do to manage it? And a lot of this, as far as how you manage potassium and calcium and phosphorus issues, are how you're going to manage them in any patient, not necessarily someone who has just has tumor lysis. So you're going to need to follow the labs closely, specifically the potassium, calcium, mag, phos, uric acid, and creatinine. There's no set frequency in how you should follow them, but if you have someone who already has tumor lysis when they come in, a high uric acid, high creatinine, electrolyte abnormalities at the get-go, then you're going to follow those patients every 4 to 6 hours with their labs. If you have someone that doesn't have any laboratory evidence of tumor lysis, then maybe you're going to follow that twice a day to begin with, and then go to once a day. So your frequency is going to depend on what you have in that particular patient. The other thing that we're going to do is we're going to really hydrate these patients. So in general, we use 3,000 mils per meter squared per day, or 1.5 times maintenance. What fluid are you going to order for these patients? Are you going to order a D5 half with 30 of KCl per liter, or what are you going to order?
Nothing with potassium.
Correct. Thank you. So we are going to give usually like D5 half normal saline. We don't want to give any potassium until we see what direction the potassium is going to go in. And we used to alkalinize fluids with patients with leukemia, but now we found that you get in more trouble with calcium phosphorus issues with alkalinization, and it doesn't really help that much with the uric acid issue. So it's really important that you give them plenty of hydration and you keep an eye on their urine output. Most of the time, you're not going to require any diuretics to keep them peeing, but occasionally you will. Let's talk quickly about hyperuricemia, and that results from the breakdown of the nucleic acids. The nucleic acids precipitate in the acidic environment of the kidney, and it's that uric acid precipitation in the kidneys that causes acute kidney injury or renal failure. We manage hyperuricemia in two ways. In general, the more common way is allopurinol, and allopurinol works by inhibiting xanthine oxidase, which is the enzyme that converts xanthine to hypoxanthine. And there's the dose right there on the screen, 100 milligrams per meter squared per dose. Sorry, my phone's going crazy. 3 times a day in general is the dosing for allopurinol. A newer medication that we use to manage hyperuricemia is rasburicase. Rasburicase, and I have a picture to show you in a second, works a little bit differently than allopurinol. It promotes the breakdown of uric acid to allantoin, which is much more soluble in the kidney. Allopurinol works by preventing the formation of uric acid, but rasburicase will actually work by breaking down uric acid. So a patient who already has very high levels of uric acid to begin with, we generally would be the patient that we would consider using rasburicase so we could break it down. It's given IV, and it is contraindicated in patients with G6PD deficiency. It can cause, and we had a patient, I think, in the past year that had developed hemoglobinemia after receiving rasburicase. They also can have very brisk hemolysis, a G6PD patient who's given rasburicase, which could be dangerous in the setting that the leukemia patient often has a low hemoglobin to begin with, and now if you give them rasburicase and then they have hemolysis, you might get into trouble. We will, if we have time, sometimes send a G6PD screen to try and kind of rule out G6PD deficiency. And certainly if it's a female patient, they're less likely to have G6PD. Here's the picture that I was talking about. I don't know if y'all can see my pointer on the screen or not. So here where we are with allopurinol, it works to prevent the formation of uric acid by inhibiting xanthine oxidase. And then here's where rasburicase is after the uric acid has already been formed. The other thing to remember about rasburicase is it's super duper expensive. So just because a drug works very well doesn't mean that we need to use it. So in general, we tend not to use rasburicase unless their uric acid is above 8, or if when they come in, or if they have a really high tumor burden and you expect to see a lot of hemolysis, then rasburicase is indicated. But the patient that comes in with a normal white count or just slightly elevated white count, B-cell ALL patient, and just a slightly elevated uric acid, then you're going to use allopurinol. Let's move on to, and y'all feel free to interrupt if you have a question, or we can wait till the end. Let's move on to hyperphosphatemia. So lymphoblasts especially, but any cancer cells have a lot of phosphorus in them. And so when you lyse those cells, that phosphorus is released into the blood. When you have phosphorus and calcium binding together, they can precipitate in the kidney, and that is another contribution to the renal failure that we can see in patients who have tumor lysis. So how do we manage hyperphosphatemia? Maintaining a good urine output is important. And then there are phosphate binders. Amphigel is what we used to use for a long time, and I don't think that that drug is available anymore, but you can use calcium acetate, and there are some other phosphate binders that help to bind the phosphorus. So basically, so it won't precipitate with the calcium and cause damage to the kidneys. Hypocalcemia can happen in our patients with tumor lysis. We talk about we don't want the calcium and phosphorus to bind together, but when they do, then that can result in a low calcium level. When you have low calcium, you can have a lot of serious issues. You can have vomiting and cramps, which makes a patient feel bad, but you can also have tetany, you can have seizures, and you can have cardiac arrest. We're unlikely to see cardiac arrest because you're going to be following the patient's labs closely enough that you're going to recognize and treat the hypocalcemia, but that certainly is a potential problem with severe hypocalcemia. How do you manage hypocalcemia? You're going to treat with calcium gluconate. And once again, you just want to be careful to gingerly correct someone's calcium. You don't want it to be excessively high, because then you're going to run into a problem with the calcium and phosphorus precipitating. Talk about hyperkalemia. I did have a question here. Well, let's talk about what happens. So the symptoms, and you get GI upset, weakness, paralysis, EKG changes. What are the EKG changes that we see with hyperkalemia?
QTC prolongation.
Okay, what else?
Peak T wave.
Right, so peak T waves, and maybe, and I'm not a cardiologist, but the QRS can sometimes be widened also. But other symptoms, like I said, the GI upset and weakness, and the same mechanism as with the phosphorus and uric acid, you have release of potassium from tumor cells. And the hyperkalemia is worsened if the kidneys can't get rid of the potassium. So if you already have a decrease in renal function, then you're going to have even more problems with hyperkalemia. How do you manage it? Let me throw out some things.
Calcium.
Okay, so calcium helps to decrease the potassium. What else?
Insulin.
Insulin, correct?
Albuterol.
Albuterol. Albuterol is a good one because you can do it pretty quickly, and albuterol helps to drive the potassium intercellularly. One other one that is we pretty commonly use, but it takes a little while to work. So if you have someone who has symptomatic hyperkalemia, then you're not going to use this one.
K-exolate.
Yeah, K-exolate. K-exolate, you can give it orally. We don't give it, it's given rectally most commonly, but we don't do that in our patients. But it does take a little while to work. So if you were if you had a patient that had EKG changes or symptomatic hyperkalemia, you can start them on K-exolate, but that wouldn't be the only treatment that I would use to try and get their potassium down. Diuretics, loop diuretics also can help bring your potassium down. Occasionally, we have a patient that has such bad tumor lysis that they need dialysis. And the indication for dialysis for our patients is the same for any patient. Fluid overload that can't be corrected, symptomatic uncorrectable electrolytes. We usually, in our patients, we're going to do hemodialysis, not peritoneal dialysis, because the hemodialysis removes the uric acid better than peritoneal dialysis. And also, it's usually a temporary issue as far as their need for dialysis. Okay, any questions about tumor lysis? Okay, so let's move on to hyperleukocytosis. And even though hyperleukocytosis can result in tumor lysis, it's really a different oncologic emergency. So, and you see other things in addition to tumor lysis with hyperleukocytosis. So the strict definition is a white blood cell greater than 100,000 is the definition of hyperleukocytosis. We see that in about 10 to 15 patients with ALL and about 5 to 20% of patients with AML. Because lymphoblasts are smaller than myeloblasts, the myeloblasts, because they're bigger and they can clog the microcirculation easier. Really at a white count greater than 250,000, you might start to see some signs and symptoms of hyperleukocytosis in someone with AML. With ALL, really not until the white count gets above 500,000 or even higher than that do you start to see some of the symptoms that we can see with hyperleukocytosis. So what's the problem? The problem is pretty much viscosity and obstruction. So the leukemia cells get stuck together in the microcirculation. The blasts are not as deformable as a red blood cell, so they obstruct vessels in the microcirculation. What are the organs most affected by hyperleukocytosis?
Spleen.
No.
The brain.
The brain, yes. The brain is one and the lungs is the other, okay? So although remember that hyperleukocytosis can, you can see tumor lysis with hyperleukocytosis, so certainly the kidney can be affected. The obstruction, viscosity issues mostly affect the lungs and the brain. What we see in the lungs is those blasts there's stasis of the blasts in the pulmonary vasculature, and that's going to block oxygen diffusion. And as those cells lyse, you can also have the release of intercellular contents that can cause diffuse alveolar damage. So this is your patient with a really high white count that has some changes on their chest x-ray and they're hypoxic. Because, y'all know that most patients with the low hemoglobin, you see those iron deficiency patients with a hemoglobin of 3, and they're not hypoxic. So it's not the anemia that is making a patient with hyperleukocytosis hypoxic. It's the damage and the damage in the pulmonary vasculature from the high white count. What do we see? We see shortness of breath. We see hypoxia. You can have right ventricular failure when you have pulmonary complications from hyperleukocytosis. The brain is the other organ, and you can have mental status changes. And with mental status changes, you can have mental status changes with hypoxia, but mental status changes also due to sludging of these in these vessels. You can have headaches. You can have seizures. You can have increased ICP and papilledema. So you have to be very aware of this possibility so you can detect any changes in your patient that might be suggestive of brain injury from a really high white count. So how do we manage these patients? So you want to keep them really well hydrated, which is what we also do for tumor lysis. And then you're likely, if they have such a high white count, you're certainly probably going to be treating with allopurinol or respiricase in an effort to decrease tumor lysis. That's not going to help the stasis in the lungs or the brain, but it will help the tumor lysis. You want to make sure that they don't have a coagulopathy, and if they do, that you manage it, because stasis in vessels in the brain or stasis in vessels in the lungs can lead to infarct or hemorrhage. So you just want to make sure that you are managing any potential risk of bleeding. FFP is often used if they have evidence of prolonged PT, PTT. Platelets are used. Platelets aren't extremely viscous, so it's okay to give someone who has a really high white count platelets. We try not to give them a lot of red cells because packed red blood cells are much more viscous, and then you're going to be contributing to the viscosity in your patient. So even if they have a hemoglobin or 6 or 7, if they're not needing a surgical procedure or needing to go to the OR, then we're going to try and hold off on giving them blood until we get their white count down. We used to, in patients with hyperleukocytosis, we did a lot of leukapheresis, so similar to how we do exchange transfusion in a sickle cell patient. You can do leukapheresis in someone who has a really high white count. And what we found is it really didn't help prevent many of the complications. And when you have to do pheresis, you have to have a big bore, usually dialysis catheter placed, and that can cause a lot of complications. And so we don't use exchange transfusion or leukapheresis anymore in the management of hyperleukocytosis. The main approach is to start treatment of the underlying disorder as soon as possible so you can start bringing down that white blood cell count. And we usually can find out within 24 hours or less when someone has a really high white count what their diagnosis is, because we can do flow cytometry on the peripheral blood and we're able to start their treatment. And that's going to start along with the aggressive hydration and avoiding giving pack cells and all those things will help to try and prevent the complications of hyperleukocytosis. Okay, what do y'all think is the next topic based on this chest x-ray?
Mediastinal mass.
Yes, very good. My questions are actually pretty easy, I think. So mediastinal mass, we'll talk about that. And with a mediastinal mass, the problems with that is compression of the superior vena cava and also compression of the trachea and mainstem bronchus. Here's an x-ray that shows a large mediastinal mass, and as you can see, that airway is pretty compressed. So meaning that, and pediatric patients, y'all know well, can compensate for a lot, but if you interfere with their ability to breathe in any way on their own, trying to get an ET tube through a narrow airway. This looks like it's I can't tell if this is the main tracheus or about when it's going to be start branching into the right and left main stem, but it would they're difficult to intubate when the trachea is compressed. So what are the signs and symptoms? Because they're not going to walk in and say, I have a mediastinal mass. So they have shortness of breath, cough, chest pain. Orthopnea is important. So you want to know, how have they been sleeping at home? And if they've been having to sleep in a chair or having to sleep with 5 pillows, then you're going to be really concerned about what might be going on in their chest. Once again, anxiety and confusion can be a sign of hypoxia. So be aware of that symptom. Syncope and headaches are kind of the things that we can see with a mediastinal mass. On physical exam, you can have facial edema, and it's usually bilateral edema, plethora, cyanosis of the face and neck, jugular venous distension. In kids, we don't see as much JVD as they see in adults, so be aware to look for it, and then wheezing and stridor. But kids can be, they can look great until they're not. You know, it does. Sometimes they can go along just fine and then they tip over the edge. So just be aware of the possibility of someone having a mediastinal mass that could be causing some compression, and the patient might not have a lot of symptoms. The big thing that we worry about and that we don't want to do is we don't want to cause a patient with a mediastinal mass to have a cardiorespiratory arrest, because as I mentioned, trying to get a tube in them can be very difficult. So if a patient doesn't want to lay down, like, oh, I don't want to lay down, and they're anxious, it might be because they don't want to lay down, because when they lay down flat, that mass is pressing on their trachea. So don't force patients to do things that might potentially precipitate a cardiorespiratory arrest. So what are the tumors that we see that can cause this issue? Tumors that arise in the anterior mediastinum classically are the tumors that are going to compress the trachea and the SBC. Although tumors arising in the middle mediastinum, if they have a lot of adenopathy, can also compress the trachea. So what are the tumors that we think about in pediatrics that are most likely to do this?
The teratoma.
Okay, teratoma is one.
Thymoma.
Thymoma.
T-cell lymphoma.
Yeah, T-cell lymphoma, and I don't know who said that, but give them extra credit because that's what we see the most, right? Thymomas aren't super common in pediatrics. Teratomas we do see in pediatrics, so teratomas and T-cell lymphoma, or a patient with T-cell leukemia with an anterior mediastinal mass, or sometimes our diffuse large B-cell lymphomas will have a large mediastinal mass. So here's our list. I have neuroblastoma on the list too. That generally is going to be arising in the posterior mediastinum, but if it gets big enough, it certainly can cause problems with the trachea or the SVC. And Hodgkin's lymphoma, because it tends to be such a slow growing tumor, it doesn't tend to compress the trachea as much, and oftentimes we will find those before they get into big trouble with SVC syndrome or respiratory issues. So here's how we evaluate them. We do a chest x-ray, and y'all know this by now, on all our new leukemia patients, because we want to make sure, we don't know what type of leukemia they have, and if they have a T cell, then maybe they have a mediastinal mass. Myeloid leukemias don't tend to have mediastinal masses, but we get that chest x-ray because we're getting ready to ask our intensive care doctors to put them to sleep, and it would be poor form for someone to be put to sleep if they had a large mediastinal mass and no one knew about it. So we get our chest x-ray. We have often, because we've gotten a CBC and a chemistry panel, a CT of the chest, if you on your chest x-ray see widening of the mediastinum, is an important test to do because it's going to help you make an assessment of their sedation risk. But you're only going to do that if they're clinically stable from a respiratory standpoint. If they can't lay down without getting short of breath, then that tells you right there that they're not going to tolerate any sedation. So you're not going to sedate that kid. How do we diagnose these kids? We want to diagnose them in the least invasive way possible. So if they have a high white blood cell count, we can often diagnose their leukemia just on peripheral blood. You can, we don't do it as much anymore, but you can do a bone marrow on someone without them being sedated, just using local. If someone has a large T-cell lymphoma, they often have a pleural effusion. If you tap that pleural fluid, and you can often do that with local. Of course, we don't like to do these things to kids because we like them to not be scared, and we don't want them to have pain, but we also don't want to precipitate a cardiorespiratory arrest. So sometimes we may have to do a painful procedure on a child without sedating them in order to get a diagnosis. In a teen who's cooperative with local, if they had a nice supraclavicular or node in their neck, they could have that node taken out probably under local without them being sedated, and that can be done. So why don't we want to sedate them? If you decrease someone's respiratory muscle tone, which you do with sedation, you also can have peripheral vessel dilatation and decreased venous return, and so you can have a respiratory collapse. And then, like I said, just anatomically, it's going to be hard to get that tube beyond that mass that is now compressing the trachea. And usually it's lower. It's not like you can say, okay, well, I could do a trach, because the compression is lower than the level where you would do a trach. So just remember that sedation is, and anesthesia, very dangerous. And our intensivists aren't going to sedate someone who has a mediastinal mass, so you don't have to worry about them doing it. You just have to make sure that you prove before they put anybody to sleep that they don't have a mediastinal mass. Same thing with anesthesia. You can evaluate patients with a CT of the chest to try and see how much of the airway is compressed. You can do echocardiograms, and it's usually the anesthesiologist that's going to make a call as to whether they feel comfortable sedating a child, and that's going to be based on the degree of compression that they see on imaging or what they see on echo. So you may have to actually start treatment without a histologic diagnosis, which is very frustrating and stressful for an oncologist, but you have to do what's safe for the kid. Most of the things that we talked about are in the lymphoma leukemia category, and steroids work very well. for B-cell leukemias, lymphomas, T-cell leukemias and lymphomas. So that often is what we will start in a patient that for whatever reason we can't get a histologic diagnosis. Radiation also works really well to treat and shrink mediastinal masses. We tend to would use that if you had more like a teratoma or something like that, rather than the liquid tumors like leukemias, because those are going to respond really, really well to steroids and respond really, really, really quickly. We have some patients who within 24 hours, the mass will be significantly smaller. And it's great that it responds quickly, but there is a small window for you to get a tissue biopsy that will show you some viable tissue to get your diagnosis. Occasionally, at the point we take them to the OR to do mediastinal mass biopsy or a lymph node biopsy, we get that tissue back and it's completely necrotic. And so then we have to, and we can't make a diagnosis. So we sometimes have to treat with what would be the most likely diagnosis in that patient. That doesn't happen very often, but it can. So before we go on to abdominal oncologic emergencies, any questions about mediastinal masses? Be afraid of them. Patients can die, so be afraid of them and have a high index of making sure you have all the people involved that would need to be involved in caring for a kid with a large mediastinal mass. Okay, abdominal oncologic emergencies, and I usually don't talk about these, but when I was kind of looking at that paper that I gave y'all, these are some things that we see perhaps a little bit more often than some of the neurologic complications or neurologic emergencies. So I thought these might be some good ones to kind of talk about. So we're going to talk about intestinal obstruction, intussusception, Tiphylitis, and Pancreatitis. For intestinal obstruction, this might not be something that you would see in a newly diagnosed patient, but when you're evaluating patients and you're getting their past history, and you find out that they had a history of Wilms tumor or some other type, or neuroblastoma or some other type of tumor that they had surgery on, they can have adhesions or strictures develop post-surgery, and sometimes even a while post-surgery. I occasionally will see a kid that I see in my late effects clinic pop up on a list and they've had an intestinal obstruction probably related to their original surgery for their tumor. So just when someone comes in with signs and symptoms, or they have a past medical history of a tumor in their abdomen that had surgery, think about the possibility of adhesions or strictures in a kid who's presenting with vomiting. Sarcomas, abdominal lymphomas, large renal, like large Wilms tumors, and neuroblastomas, and then ovarian and colon tumors, which we don't see very often in kids, can certainly cause adhesions or strictures post-surgery at any time, either right after or a prolonged period of time after. And let's not forget about our medications also. Vincristine is the classic one that we think of causing usually just an ileus, not an obstruction, but certainly we have patients who have significant problems with ileus that it almost behaves like an obstruction. Same thing with narcotics. We have to always be cognizant of when we're giving pain medicine and what kind of pain medicine we're giving, what that might be contributing to your patient's ileus or potential risk for obstruction. So if you have someone who has a small bowel obstruction or signs and symptoms of a small bowel obstruction, which would be bilious vomiting or abdominal pain, what's going to be your initial workup? So someone comes in with bilious vomiting and abdominal pain, what are you going to track? This one isn't tricky. any patient that comes in with bilious vomiting and abdominal pain, what are you going to order?
Abdominal X-ray.
Yes, thank you. And we're not big on abdominal x-rays when you're trying to look for cancer, right? Because a lot of times it's not going to tell you anything. But if you have signs and symptoms of a small bowel obstruction, then, seeing an x-ray that has, dilated loops of small bowel and air fluid levels, and if you don't have any gas or stool distally, then that's going to tell you that this patient has an obstruction, and that's going to be important to be able to get your surgeons involved. So the plain film in the setting of the possibility of small bowel obstruction is very, very helpful. A plain film in the setting of abdominal mass oftentimes is not very helpful, but in the setting of small bowel obstruction, it is. So let's move on to intussusception. And so y'all tell me, what are the signs and symptoms of intussusception? The classic signs and symptoms in the classic age.
Intermittent abdominal pain.
Right?
Bloody stools.
Right? What's classic age?
3 months to 3 years.
Right. Okay. So if you have a kid that comes in that fits that description and they're 2 years old or 3 years old, then that's going to probably be what it just kind of your general intussusception. When we think about intussusception in the world of oncology, we think of the lead point for that intussusception being a tumor. So what's the tumor that can be the lead point and that we see in pediatrics for an intussusception? Anybody? This is a good one to know. This would
What
be
was the question?
What is the tumor that we see in pediatric oncology that would present with an intussusception?
Abdominal burgers?
Yes, yes. So if, so if you had a 6-year-old or an 8-year-old that presented with the classic intussusception, you just want to have a high index of suspicion that they're going to have a lead point more than just like, increased intestinal, whatever, I don't know what, Peyer's patches or whatever usually triggers intussusception in little kids. So when you have an older kid that doesn't fit the classic age, think about whether or not could they have a Burkitt's lymphoma. That's the lead point. And this is just an abdominal x-ray showing an intussusception in someone who did have a Burkitt's lymphoma as that lead point. And CT scans are pretty, you can diagnose an intussusception often on ultrasound as well as CT scan. So remember, older child, and the length of the intussusception, the longer the intussusception length puts you at increased risk of it actually being a tumor or something more significant than your classic intussusception. Let's talk a little bit about Tiphylitis. Tiphylitis is, we see in our kids fairly frequently. You have the pathophysiology is the destruction of normal mucosa by chemotherapy. And then you have bacteria, or you can have fungal invasion of the bowel. And you have decreased defenses because you have neutropenia. So this is kind of the perfect storm when it comes to Tiphylitis. And how do they present? Abdominal pain, and classically it's often localized to the right lower quadrant. Y'all know with kids, abdominal pain is hard to evaluate because when a kid feels poorly in general, they sometimes say that their stomach hurts. But with Tiphylitis, it's classically that right lower quadrant pain, also kind of how someone with appendicitis would present. They will often have fever and diarrhea. They're usually in the setting of neutropenia at that point. And so that's why when we have fever and neutropenia, it's always important to pay attention to the abdominal exam. What do we see radiographically? You have bowel wall thickening, and then you also have pneumatosis intestinalis. So similar to how an abdominal film would look on a NICU baby who has neck. I mean, it's the same type of pathophysiology. So this is a CT scan. You can, I often will do a CT or maybe an ultrasound to look for Tiphylitis. Sometimes to follow patients after they've been diagnosed with Tiphylitis, I will follow them with serial plain x-rays, mainly just looking for free air. So mainly just looking to see if they get sick or do they have a perforation, because that's potentially a surgical emergency. So how do we manage Tiphylitis? What are some things that we do for Tiphylitis? Pain management. So yeah, we want to manage their pain. What else?
Bowel rest and antibiotics.
Yep. So, and with that bowel rest, that means that we're going to be giving them TPN and then also antibiotics. And the broad spectrum antibiotics, we want to make sure that we cover both anaerobes and gram-negative organisms. We tend to have to use TPN for at least 2 weeks to make for them to get, usually takes about that long for their bowel to heal, and then close monitoring for perforation, either clinically with increase in pain, decrease in bowel sounds or absent bowel sounds, and then certainly an X-ray could help monitor for free air for perforation. So what about pancreatitis? What causes pancreatitis in our patients?
Chemo.
Right, and which chemo?
Asparaginase.
Yes, so asparaginase is the biggest one, and that would be the one on the test, but interesting, other drugs like 6-MP, which we use a lot, steroids can cause pancreatitis, and I don't know that I've ever seen it, but Septra has been reported to potentially cause pancreatitis, and we certainly use Septra in our patients. What presentation for chemotherapy-induced pancreatitis is the same as viral-induced pancreatitis. Patients will have abdominal pain, nausea, and vomiting. It tends to be pretty severe, and it tends to be kind of centrally located in the abdomen. So if someone is having abdominal pain more centrally located versus that right lower quadrant pain, that might help you in your differential between pancreatitis and Tiphylitis. Where they are in their treatment is important. So if someone got asparaginase 2 days prior to coming in and they have now abdominal pain, nausea, and vomiting, then you really need to think about pancreatitis as being on your differential diagnosis. And laboratory-wise, it's pretty easy, right? You're going to get an amylase and a lipase, so it's pretty easy to diagnose pancreatitis once you think about it. And then imaging, where imaging helps you is just kind of getting an idea. I mean, as y'all know, patients with pancreatitis can be really, really sick, but you can take a look at the pancreas with imaging and they might have an enlarged pancreas, usually hypoechoic on ultrasound, and you can often have a lot of peripancreatic fluid. The other way that imaging helps you with pancreatitis is kind of post the initial kind of flare of pancreatitis, patients are at risk of developing pseudocysts. So you think the patient is getting better from their pancreatitis, and then they start having more pain again and more issues, and they have developed a pseudocyst. Like I said, these patients can be very, very sick. They can have third spacing, fluid and electrolyte issues. You can have hemorrhage in the pancreas and significant necrosis in the pancreas that leads to insulin dependence. We've had a couple of patients that have had pancreatitis that now essentially are insulin dependent diabetics because their pancreas just doesn't work anymore. Pancreatitis is one of the indications for not giving someone asparaginase again because pancreatitis is a life-threatening complication. And then as I have on there, also pseudocyst. So I talked faster than I usually do. Maybe it's because I'm not pausing because we're virtual. So I think just reading about and thinking about some of the abdominal complications that we see is important, in addition to kind of your classic mediastinal mass and hyperleukocytosis and hemolysis. So does anybody have any questions? Before I share my special last slide, because you know I have to have a special last slide to share with y'all. No questions? Y'all ready for the special last slide? Okay, so when I was practicing in Chicago, we had a cancer camp just like we do here. But when I was practicing there, I wanted to be a counselor rather than work in the with the med staff, because I get to be on the med staff all the time. So I actually was a counselor for a lot of summers when I worked at that camp, and we did a lot of really fun things. And one of the things that I discovered is that I have a talent, a hidden talent of that I can be a clown. And we did clowning. And so this is me as a clown many years ago. And I think I look really pretty good. And I may choose this as a retirement job or maybe a second job opportunity. So Bonnie, my friend Bonnie, actually has this picture on her computer in her office so that she can just laugh at it when things get difficult. So that's my fun picture. Y'all enjoy your day.
Thank you.
Thank you.
No.
Thank you.
Bye.